Gazuhem Choyam Kutu. It's a pleasure to be here all the way from America, and I thank you all for taking the time to join me for an update on prostate cancer, specifically the insertion of MR imaging into the workup of men with prostate cancer or suspected of having prostate cancer. I'm going to talk to you today about a number of things, some of which can be implemented here, some of which can't, but that's okay because we have to start somewhere. The learning objectives for today are to understand the role of MRI when properly inserted into the diagnostic workup of men with suspected prostate cancer, and also to discuss the evolution of prostate biopsy, the benefits and drawbacks of various techniques, and the basics of implementing an MR-based prostate program. Now, I added some additional objectives because I just came back from New Orleans, the American Urological Association meeting, and ASCO, the American Society for Clinical Oncology meeting. Both of those meetings had some substantial impacts in terms of clinical care management and also research. So we'll discuss some of that as well. But we'll begin with an introduction. I'll talk about a history of how things evolved with a literature review. I'll give an overview of multiparametric MRI, MR-guided intervention, and then I'll talk a little bit about the focal therapy program that I oversee in Indian Wells, California. I have no disclosures to make, and I think that's important for everyone in the audience to understand. I have no affiliation with a corporate vendor. I have no affiliation with pharma. Again, I'll go over AUA and ASCO updates. We'll talk about epidemiology, a literature review, biopsy techniques, current therapies, combined therapies, precision medicine, and focal therapy, my favorite. And just to give you some hope, I know Kosovo is a recovering nation. You have a lot of work to do economically, politically, and certainly medically. There's a lot of work to be done, and I think it starts from the ground up. And I thank Dr. Miftari for the kind invitation and wanted to share with you a proclamation that came to me recently from the governor of Wisconsin declaring June 4th Prostate Cancer Awareness Day. So if one person, little me, can do that, you have the collective power to also make changes here in Kosovo. So the hottest topics at ASCO, I'll give you the top 4. Biomarkers, precision medicine, the role of imaging, and management of advanced prostate cancer. There were other topics that people talked about at ASCO, but those were the top 4. And when we look at what's going on, in the United States, there's this known incidence rate that's pretty substantial. There's also a comparison to other cancers, and you can see prostate cancer is the 3rd most frequently occurring cancer in the US. So I took a similar approach with Kosovo, and I learned a lot about my geography in studying in preparation to come here. It's a tiny country, but I've learned that its people have very big hearts, and I think the men of Kosovo deserve the same kind of attention that's given to the men of other countries in terms of screening, detection, diagnosis, therapy delivery, and follow-up. When we look at 1, 3, and 5-year prevalence of prostate cancer in Kosovo, you can see that it's the most commonly occurring cancer in men. I'll go back to what's going on in the United States briefly and just show you a comparison of breast cancer and prostate cancer. We can see that the incidence is around 230,000, and the mortality is around 40,000 for breast and 30,000 for prostate. Very similar, right? But let's look at funding. When we look at NIH dollars in millions, for breast cancer, we've got over 600 million. For prostate cancer, 288 million, down from over 300 million the year before. So this reflects the hesitancy of men to discuss prostate cancer, to bring it to the forefront, and to make it as big a campaign as breast cancer. So again, we can change that collectively. I think we have the power and the resources to do that. So how did we get here? First of all, we've had PSA since the 80s, and we've had digital rectal exam, both of which have fairly low sensitivities and specificities. Even when combined, these tests still have low sensitivity and specificity. So how did this happen? We're going to take a walk through time from the 1920s until today and look at how techniques have evolved for diagnosis of prostate cancer. So back in the 20s, we would do an open transperineal biopsy. And then in the 30s, a technique was developed to insert a sound down the urethra, palpate the gland with a finger, and do a digital guidance of a needle into the posterior aspect of the gland. Better for the patient than the other way, but not as sensitive or specific as it could be. Then in the 60s, Watanabe and his team in Tokyo came up with the first clinically useful ultrasound images, and at that same time, McNeil developed zonal anatomy. So it's very important when we discuss prostate cancer to be able to talk about where the lesion lies in reference to known anatomic features. So from a surgical or pathologic or imaging standpoint, it's useful to have the zonal anatomy to refer to. In the 80s, we had wonderful development of transducers. Intracavity transducers allow us to do imaging of small structures of the pelvis. We had PSA testing, FDA cleared in the United States for screening of prostate cancer. And then sextant biopsy evolved as a systematic, random way to sample tissue for histologic evaluation. Then, because sextant biopsy didn't perform at a level that was useful in terms of timely detection and accurate staging, another mechanism was developed. Instead of only sampling the 6 cores, as indicated by the red dots here, laterally directed extended biopsy schemes were developed by Stamey and Eskew. Now, although these are extended schemes, they're still random. So what if the cancer's here? What if it's here? What if it's here? And this is just sort of an illustration of what you see under ultrasound. You can see the margin of the gland, but with MR, you get much more detail in terms of both, anatomy and morphology, and we have additional sequences that we can run that are functional in nature, like perfusion and diffusion. What problems do we run into with random biopsy? Well, the biggest problem is that we miss the thing, right? So the needle gets inserted, and the man is harboring clinically significant disease that's never detected. So this guy will go on active surveillance for however many years while he's harboring aggressive disease. Another situation is the biopsy is performed, and we pick up infection, inflammation, or low-grade disease where higher-grade tumor is unsampled. And then another possibility is that the lesion is heterogeneous and there is an aggressive component, but we only sample or skim the edge of it. And this is just a function of the reach of the urologist needle. When we do random biopsy, we're only going so far in this direction, and meanwhile there's an aggressive lesion living far anterior. And again, this is the laterally directed extended schema. And this is accomplished by using a template, and no matter what the size or shape of the gland, you do just ABC 1, 2, 3. And a saturation biopsy requires a lot of ancillary equipment, and the ultrasound is used to localize the margin of the gland, as I mentioned before, and that's all we see. On this image, what you could see is the gloved hands of the fellow. You could see the handle of the transducer in his gloved hands, and you could see the needle entering the prostate gland. This is the inferior wall of the urinary bladder, this is urine, and this is the prostate. So the question is, where's the needle going? I don't know. Do you know? So Poor patient, right? And the poor man, he's got a nerve block or he's under anesthesia, and we do, like I said, ABC 1, 2, 3, and end up with this. So now in the United States, these cups are very expensive to evaluate pathologically. So we get to the point where, do we want to sample many randomly, or do we want to sample fewer targeted? So what we were able to do is devise a mechanism for insertion of a device, a very tiny needle guide that gets inserted in the patient's rectum. MRI has shown that we can pick up lesions that are aggressive using imaging functional sequences, and then use this needle guide to aim at a specific target rather than poking and hoping multiple times, going specifically for the most aggressive looking tumor. And the good thing about this needle guide is that it functions two ways. It's both a receptacle for a biopsy gun and it's a fiducial marker. Because it's very tiny and only the size of my index finger, it's inserted into the man's rectum, and when we image in the sagittal plane, it appears as two bright parallel lines. A computer program shows us where the tip of that is in XYZ space, and then we image the man in the axial plane, localize the tumor, and then calculate the delta between those 2 points so that we can aim using this device in order to plan the trajectory to get the sample. Now, again, I said at the beginning, I'm going to show you some things that can be done here today. There are other things that may take years to implement, but this is to give you kind of the landscape of what's out there, especially in the United States. So the device that's used is simply a clamp stand that's a device holder. The needle guide that I described is this plastic piece with a gel-filled center so that we could see the two bright lines. And then the biopsy guns, they're different than what's used in urology because, as you all know, in MRI, you can't bring ferrous objects. You can't bring a stainless steel needle because it's not imageable and it could become a projectile. So these are made of titanium. And another thing that's evolved in the very recent past is MR ultrasound fusion. So our urologists are used to doing their biopsies under ultrasound guidance, but they recognize the value of MRI. So one mechanism to be able to accomplish this is to use the historic MR data, import it to a device that will then lay the real-time ultrasound on top of the historic MR data to provide the little target area that's to be biopsied. And what does a multi-parametric MRI consist of? It's essentially a T2-weighted fast spin echo in the axial, coronal, and sagittal plane, T1-weighted fast spin echo axial, if there's a recent biopsy to kind of sort out the blood products and hemorrhage. Diffusion-weighted imaging with a B-value of 1400 or higher, that can be acquired at MR or it can be calculated post-acquisition. Apparent diffusion coefficient maps, dynamic contrast enhanced, and CAD post-processing is something that's frequently used in areas of Europe and also in the US, but you don't need it. What you need to know is there rapid wash in and is there wash out? And if you see perfusion, that's a hallmark of malignancy. It's also an indicator of infection and inflammation, but with the combined multi-parametric sequences, it's if this and that, then this. So you should be able to develop your workflow in terms of search pattern based on the properties of each sequence, meaning if it's dark on T2 and it perfuses wildly on DCE and it exhibits restricted diffusion, likely you want to stick a needle in it, right? And I'm going to go back here. Minimum field strength has been agreed by the ACR and most experts in the field that 1.5T and 3T are equally good at detection and localization of clinically significant disease. And I'll say it twice because it's really important. A lot of people think more is better. 3T doesn't necessarily mean that the images will be better. Because we know anything at 1.5T that is a problem becomes more of a problem the higher the field strength. So 1.5T is as good as 3T for detection and localization of clinically significant disease. We don't pick up the stuff that doesn't matter because we don't care. We're not going to do anything with it anyway, right? So this is what the CAD program looks like. Clearly, I would not expect University of Pristina to implement a program like this, but if you have an MR guru that would like to send me DVDs and maybe I could process a couple cases, I can help you with that. So let me know if that's something you would like to do. And we can also use them as teaching cases too. On the topic of field strength, there has been debate over the years, but that was resolved, as has the endorectal coil quandary. Some folks think you absolutely must have an endorectal coil for all MR imaging of the prostate. Clearly, if you're looking for nerves and you're doing pre-surgical planning and staging, endorectal coils are helpful, but for detection and localization, a surface coil is perfectly fine. And I've written up a couple of cases on men with AP resection. They don't have a rectum, so you can't use an endorectal coil on them anyway. So what are the hallmarks? T2 shortening, restricted diffusion, and increased vascular permeability at DCE. Now, the PIRADS lexicon was developed and published at the end of 2014. This was an offshoot of the European Society for Urogenital Radiology Prostate MR Guidelines of 2012. There is consensus on the language that should be used to describe MRI findings, so that's helpful for reduction of inter-observer variability. And here are just some illustrations. You know, we talked about the T2 weighted sequence. What we get concerned about is a teardrop-shaped lesion and things that are dark on T2. And we'll talk about diffusion. What is diffusion? Everyone's familiar with Einstein's theory of Brownian motion, and that's the random movement of water between cells. Anytime you have infection, malignancy, or inflammation, that ability of water to move around is going to be restricted. The cells get very compact, so you'll see really exquisite detail when you do a ADC map. Suddenly there's this area of restricted diffusion where all the other tissue is bright, and then on the high B value diffusion, it looks like a light bulb. And I have a couple of young children. I bring my computer home and I process cases a lot, and I have a 13-year-old who's been looking at these images with me for about 10 years. He's like, "Ooh, Mommy, there's the cancer." So the high B value diffusion makes it light up like a light bulb. And then this is the perfusion. You should be able to see it on a T1 weighted sequence, but if you have ability to do CAD post-processing, it just shows up a little more obviously. And we can also do quantification in terms of the kinetic properties of the contrast. And so years ago, we proved pretty effectively why MRI wasn't very good. In the early 80s, we didn't have the magnet technology, we didn't have the coils, and we certainly didn't have the pulse sequences. So just doing a T2 wasn't necessarily very helpful. But now that we've got multiple sequences that we can run, we can combine the T2, the diffusion, the DCE, and some folks like to do spectroscopy, but even without it, the area under the receiver operating curve is 0.91%. That's a pretty decent test. So the negative predictive value of MRI for clinically significant disease is extraordinarily high. So specifically for Gleason 4+3 and greater, it's 97%. That's a darn good test. And for Gleason 3+4, it's 90%. Very favorably compares to trust biopsy, which has a negative predictive value of about 65%. So absence of a tumor suspicious region on multiparametric MRI has a negative predictive value of over 96% for the presence of high-grade disease in an active surveillance cohort. So earlier this year, the group out of Johns Hopkins did a study evaluating MRI invisible lesions versus visible prostate cancer in an active surveillance cohort. And the take-home message is essentially the same thing, that MRI is very good at picking up what matters and not so good at picking up what doesn't. And the reason why, like I said before, we now have body coils and high channel count surface coils to do very fast scanning with uniform signal intensity. We can do motion compensation, fat suppression techniques, diffusion for enhanced lesion detection. and small field of view imaging. And our European colleagues have led the way, Professor Jelle Barends in particular, out of Radboud University Nijmegen. And I like this quote from Wyatt Earp, "Fast is fine, but accuracy is everything." A lot of people say, well, in ultrasound, we could do that biopsy in 10 minutes. 10 minutes doesn't matter when you get it wrong, right? So let's take a couple more minutes and do it better and do it right. And this is what it looks like for the patient. So the man lays prone on the table. We have him wrapped in a body coil, a surface coil. Transrectal access has been gained by the needle guide I showed you earlier. And we have our radiologist, our interventionalist there, inserting the biopsy gun. And this is what the specimens look like in formalin and the photomicrograph. Super simple. And when we look at the evolution of the Gleason grading system, that's beyond the scope of today's talk, but you can go to the guidelines for Gleason grading and learn more about how it evolved. But there's actually talk of yet a new grading system, so brace yourself. For the purpose of today's lecture, I'm going to go with the classic Gleason scoring system just because I like Skittles. I call it Skittle sorting, which is essentially what it is. I don't know how many technologists and nurses are in the room, but if you don't understand Gleason scoring, it's very simple. When that biopsy specimen is taken out of the formalin, the pathologist puts it under a microscope, and they look at it and they figure out what's the most dominant cell type, and that's the primary Gleason grade. Then they look and they see what's the second most prevalent cell type, and that's the secondary Gleason grade. The sum of those two is the Gleason score. So a man comes in and he has a biopsy, and we look under the microscope, and the dominant cell pattern is Gleason 3. And the secondary pattern is Gleason 4. He's a 3 plus 4 equal to 7. Another guy comes in and we look under the microscope, and his dominant cell pattern is Gleason 4, and the secondary is Gleason 3. He's a 4 plus 3, also equal to 7, but his prognosis is worse. And the reason is because the dominant cell type was 4 architecture, not 3. So hopefully that makes sense. So again, I had mentioned the evolution of the ISUP modified Gleason system. This is a helpful paper for those of you that want to look into it a little bit more. So I'm just going to skim over genomic testing. So these assays that have developed over the last 10, 20 years, they're very promising. The question is, well, how do we implement them today? What's the best mechanism for risk stratification and placement on active surveillance and selection for focal therapy and all these things? We don't know. So there's a number of tests that are done. Prostavision, Prolaris, Oncotype DX are gene panels that look at presence of, absence of, and behavior of certain genes. Confirm MDX is for negative biopsies in settings where the man is really suspicious for cancer. And Decipher is a genomic panel that's done on post-prostatectomy tissue. So in our practice, we use a couple of these, and we're looking at our focal therapy recipients, and we're going to do some retrospective analyses of what their genomic profiles look like prior to therapy and how they're looking at 5 and 10 years, and see what we can learn about the prognostic capabilities and predictive capabilities of genomic testing. So guidelines drive everything, right? So when you're looking for justification to take step 1 in this kind of a program, all you need to do is look at the guidelines. You know, it used to be back in 2009, we would just repeat the biopsy, repeat the biopsy, repeat the biopsy. Meantime, the guy's PSA is going through the roof, and nobody's got any other alternatives. Well, now they say insert multiparametric imaging in there, okay? And even in the absence of any device to do the biopsy, at least you can do cognitive fusion and you know where to aim, right? So let's look at MRI in the United States and how it evolved. So the MR volumes reached 3.49 million in 2014 for all MRIs. And if we look at what happened with prostate MR, in 2000, so that's 14, 13, 12, 11, you could see this kind of upswing. in the performance of prostate MRI. Now, even though the volume in the year 2014 was only 1% of that 34.9 million, the growth was 150%. So it's being adopted, and we're going to see over the years even more of an upswing, and it's going to look a little bit more like this. And the reason why is because all the reasons we shouldn't be doing it were things like inconsistency in description of the suspicious lesion. We now have ACR guidelines and PIRAD's lexicon to standardize acquisition and reporting. Again, this reduces inter-observer variability and gives the urologist, the oncologist, and the radiologist a common language. So back in 2009, I mentioned it was PSA, DRE, repeat biopsy. Now, repeat biopsy and do multiparametric MRI. We all know that the European guidelines are what spurred the evolution of the American College of Radiology guidelines. And a lot of the work that was done at Radboud University, Nijmegen in the Netherlands. And what they were able to show is in men with a PSA between 4 and 20, the respective cancer detection yields for second truss biopsy, which is the blue bar, third truss biopsy, which is the red bar, and MR-guided biopsy, which is the green bar, is 15%, 8%, and 59% respectively. So when the new way is 4 times better than the old way, our thinking needs to kind of go with it. So again, the same institution did some really good work comparing 10 core biopsy to MR-guided biopsy and had a more than double in the cancer detection yield. I don't even need a p-value to show you the statistical significance of that. So in the United States, we've had some evolution of guidelines for PSA testing. Some say do, some say don't, some say 45, some say 55. The bottom line is there needs to be shared decision-making between the patient and the clinician to determine what's the best age, if at all, for screening, and take into account ethnicity, family history, clinical presentation. PSA in a vacuum as a standalone number is not quite as helpful as PSA velocity, and PSA density and other derivatives of PSA can also be helpful. So once we have all this information, what do we do with it? Well, it used to be that you had some extremes. You had do nothing and put the man on active surveillance, or you had radical treatment, including surgery, radiation, and hormone therapy. Focal treatment has evolved as a viable option in some men that are carefully selected. We've used various energy sources and delivery mechanisms in MRI to treat only the lesion and avoid structures like the urethra, the neurovascular bundles, and the external urethral sphincter. So this came around very much like breast MRI, which is a complement to mammography and ultrasound. We use MR breast intervention for a targeted biopsy, and the ACR practice guidelines in the United States say if you could see it with MRI, you should be able to biopsy it under MR guidance, either yourself or a colleague. And back in the days where it was mastectomy, we now have the option for lumpectomy and focal treatment. Prostate is a similar model. We've got complement to PSA digital rectal exam. Using MRI for intervention to target the biopsy gives us possibility of MR ultrasound fusion, in-bore biopsy, or cognitive fusion. And then we're able to do focal therapy versus whole gland radical treatment or prostatectomy. And I always say if it looks like a skunk and it smells like a skunk, it's probably a skunk. So if I can put a needle into the lesion, confirm that it's lower intermediate grade disease, there should be a mechanism to ablate the tumor without damaging anything else. So currently what we have available for patients is surgery, radiation, hormone therapy, some focal therapies, and active surveillance. In a database of 10-year disease-free survival, the numbers speak for themselves. In the men who are diagnosed early with low-grade disease, the survival is much better than the men with higher-grade disease, managed either with surgery or radiation and conservative treatment. At the AUA meeting, we saw lots of papers and abstracts on the evolution of MRI using an MRI-based program, performance of in-bore MR-targeted biopsy. We also saw MR ultrasound fusion on lots of papers, scientific posters at the podium, and then also correlation with genomic panels and how we can better stratify these men. And I love this. This was the headline at the AUA on the first day. So imaging increases potential for more patients to receive focal therapy. At the meeting, what I observed was there was a lot of talk about biomarkers and a lot of talk about imaging kind of independently. I think the holy grail is to be able to put those two things together and be able to use imaging for the purpose of taking specimens for genomic testing. And at ASCO in Chicago, there was a similar message. But the strange thing for me was at this conference, the talks were all geared towards metastatic castrate-resistant prostate cancer. Very, very little on how to manage the man with low or intermediate grade disease. And I think the key, again, is imaging plus biomarkers. And the reason why is, like I said before, if you could see it with MRI, you could target it with MRI. If you could target it with MRI, what you're looking at under the microscope is better classified, and then your genomic testing is going to be much more meaningful. So the immunotherapies, the chemotherapies, and all these precision medicine drugs that are being developed today, they're being developed on prostatectomy specimens, post-therapy specimens, and random trust biopsy specimens. Imagine what progress we'll make if we can actually get in vivo targeted specimens for the purpose of development of precision medicine. I like this quote, and I'll read it to you. In order to pursue chemotherapy successfully, we must look for substances in which possess high affinity and high lethal potency in relation to the parasites, but have a low toxicity in relation to the body, so that it becomes possible to kill the parasites without damaging the body to any great extent. We want to hit the parasites as selectively as possible. In other words, we must learn to aim, and to aim in a chemical sense. The way to do this is to synthesize by chemical means many derivatives as possible of relevant substances. And when I go back to that one slide and I show, the MR image, this is where we're going to get the most meaningful information for the development of those targeted therapies, right? So now, instead of what's that handful of available therapies, we're going to have much more targeted chemotherapeutic agents and immunotherapeutic agents. So if you want to visit the ASCO abstract database, it's online, and you should be able to look at the expert opinion forums and see what the Stampede trial and all the other trials showed in terms of management of aggressive disease. So, and the other topic that I wanted to talk about was combined therapies. The ability to use androgen deprivation in combination with other therapies, or chemo in combination with other therapies, is really evolving, and the men who have been best served have been using the docetaxel regimen, and I know abiraterone and enzalutamide have also been studied at great length, and so there's a lot of hope once we start getting biopsy specimens that are targeted to be able to combine therapies in a meaningful way. So when we look at skin cancer, you don't want to end up like St. Bartholomew with a skin over your shoulders just to remove one small lesion. I don't know that we should be doing that in prostate cancer either, especially if we can stage the disease and grade the disease better than we ever could in the absence of focused biopsy. So in the United States, we have a database called clinicaltrials.gov. I oversee a prostate cancer clinical trial that's purely MRI based. We image our men, we biopsy our men under MR guidance, we deliver focal laser ablation to low and intermediate grade organ confined disease, and we follow the men with MRI. That's the primary arm of the study. We have another arm of the study that's salvage patients who are not candidates for any other method of treatment, who have undergone some other modality, and they have recurrence. The way that we do it is very much like the way we do the biopsy. We use that little needle guide, which is just about the size of my index finger, and that's my finger. We use a water-cooled disposable laser probe. It's a 980 nanometer diode laser that gets inserted down the needle guide. We use a visualization system that lets us deliver the laser and watch a thermal map as we're ablating the cancer. It's a 15-watt laser, simple computer with software for real-time prediction models, and this is all cleared by the regulatory bodies in the United States. What a lot of people don't understand about MRI, and I use a food analogy, it's like baking a cake. When you make a cake, you need eggs, flour, sugar, water. When you make an MRI, you have echo time, repetition time, flip angle, bandwidth. The echo time of the acquisition contributes to the signal intensity of the tissue, and it lets us exploit things that are abnormal and identify them. But what it also lets us do is measure phase shifts in the hydrogen protons in the body. That's very helpful for perfusion measurement, for diffusion observation and quantification, but also for thermal mapping. So this is an image of a case we did very early in our experience in 2010. We were able to define the lesion and draw a contour around it, and then administer a non-therapeutic dose at a very low temperature to localize the lesion and the tip of the applicator, and then we increased the power on the 15-watt laser to 100% and cooked the tumor. And you could barely see this cursor here. We're protecting the rectal wall with a cursor that creates a safety zone, and if the temperature exceeds a preset threshold, it shuts down automatically, so we don't risk injuring anything vital. And then here is a damage estimate, and you can see that needle guide. This is the same device that we use for the biopsy. We can also use it for delivery of focal treatment. And to date, we've done, we've done a few more since I got here, but about 39 patients. We're up to 60 treatments, so some of our men have more than one treatment or more than one lesion. We did 4 salvage patients for biochemical recurrence. We had 56 cancer foci. The age of our patients ranged from 50 to 81. The PSAs, not surprisingly, some were as low as 0.9 and some were as high as 28. The tumor volumes ranged from a grain of rice to a small grape. And in terms of what kinds of cancers we saw, 3+3s, we had 15 foci, 3+4s, 23, and 4+3s, we had 12. And most of these occurred, as you would guess, in the peripheral zone. Central zone lesions were much more uncommon. In our salvage arm, we had 2 men who had undergone brachytherapy, and on them we treated 3 lesions total. 1 man had 2 and 1 man had 1. We had 1 man with proton beam and 1 man with cryotherapy. These cancers ranged from 3+3 all the way up to 4+5. The 4+5 was my proton beam subject, and he's down to a PSA of 0.4, and he's very happy. So the total procedure time when we do these lasers, it runs from about an hour and a half to 4 hours with a goal of eliminating the MR visible lesion, and we do 1 centimeter margin around it. So far, no serious adverse events, no morbidity. 2 guys got asymptomatic periprostatic necrosis. We had 3 gentlemen who developed retention cysts and 10 patients with positive biopsy at the retreatment site consistent with residual or recurrent cancer. So that's a positive margin rate of around 26%, which compares very favorably to surgery and cryo. 7 patients were retreated with laser. And in both our salvage arm and the treatment naive arm, we saw a PSA drop of about 47%. 1 year post-treatment. Our international prostate symptom scores didn't change with any statistical significance, nor did our sexual health inventories. So this is good news for the men who want to have the urologic trifecta, which is oncologic control, preservation of sexual function, and preservation of urologic function. In terms of withdrawal, we had one guy who passed away from metastatic melanoma, one withdrew for personal reasons, one withdrew right after a negative 6-month biopsy. Post-treatment, we biopsy everybody again at 6 months. We go to the treated region and we sample to make sure there's no microscopic residual disease. 4 went on to whole gland treatment. 3 incidence cancer patients and who had 4+4 and 4+3, and 1 had multifocal disease and elected radical prostatectomy. And the surgeons tell us that there's no additional technical difficulty after the laser, because when you look at what we're doing, you know, the prostate is the size of a small plum. We're inserting something the size of a large tapestry needle, puncturing only the gland, doing what we're doing, and getting out. So the periprostatic tissue, nothing's disturbed. There's no necrosis outside the gland. Everything's happening inside the gland. So surgical dissection's not compromised. And then our incidence cancer rate was only 8%. And one of our men who had 4+4 diagnosed at biopsy was downgraded to 4+3 at surgery. So he could have theoretically remained in the focal treatment program. So of our small series, what we've concluded is the outpatient MR-guided transrectal laser focal therapy of prostate cancer is both feasible and safe. It can be done. The positive margin rates are acceptable. Our whole gland therapy rate was 10%. Patients remain treatment viable, retreatment viable to have laser over and over, or they can go on to surgery. And then I like the continuity of imaging modality. Again, we use multiparametric MRI for diagnosis, we do it for localization for biopsy, and we do it for delivery of focal treatment and for follow-up. So our research team consists of myself, under the leadership of our PI, Dr. John Feller, our interventional radiologist, Dr. Stuart May. My research partner has passed away, but his name was Roger McNichols. My colleague in Schwerin, Germany, Axel Winkel, the patent owner for the delivery device, and our tech, Wes Jones. So I also want to acknowledge my professor at University of Edinburgh, where I'm a graduate student, and Elda Rayleigh and Tom Kirk, my advocacy partners. So the take-home messages for University of Pristina. Number one, and most important, establishing an MRI-based prostate cancer program is a multidisciplinary team sport. We want a head honcho, we want the leader to spearhead this initiative, but we want also buy-in from other disciplines to ensure the program succeeds. Take-home message number 2, very important, trust biopsy misses 30 to 35% of prostate cancers and has led to overdiagnosis and overtreatment of clinically insignificant cancers. Take-home message number 3, multiparametric MRI misses only 3% of Gleason score greater than or equal to 4+3 and only 10% of Gleason score 3+4. When combined with MR-guided biopsy, the negative predictive value is significantly improved over random systematic transrectal ultrasound-guided biopsy. MR-guided prostate biopsy exceeds the cancer detection rate of second or third trust biopsy sessions. We saw the histograms put together by the team at Radboud. And take-home message number 5, trust biopsy undergrades the Gleason score of prostate cancer 30 to 40% of the time. So what woman in the room would accept being told by a doctor that we're going to stick 12 random needles in your breast and tell you if you've got breast cancer? None of us. But men have quietly accepted this as the standard of care for 30 years. So we have the technology, we have the expertise, and we can do better. Multiparametric MRI combined with MR-guided biopsy undergrades a Gleason score of prostate cancer only 5% of the time. So while there is no perfect test, this is a darn good test. MR-guided prostate biopsy can be done quickly and easily and safely in an outpatient setting. Our practice is an outpatient-based setting, and we get them done in a half hour, on and off the table. Once you've done 10 or 12, it's very simple. You know, doing the first 2, you got to reserve 2 hours, and you take it slow and you learn, but then as you've done more and more, it gets to be very easy, like anything else. Multiparametric MRI combined with MR-guided biopsy is cost-effective and improves quality of life compared with trust biopsy strategy. And, as I said, 1.5 Tesla with a surface coil is perfectly fine for detection and localization of clinically significant prostate cancer. And you will help the men in your community. So MRI is the GPS, the Global Positioning System for detecting and localizing prostate cancer. And if you have any questions about anything you saw or heard today, this is my email address. Dr. Miftari has access to me by phone and by email. He can share that with you also. For those of you who are physicians and you would like to claim CME credit for today's time, you could send me an email and Loma Linda University will issue your CME. Any questions? Thank you. Any questions? I know I couldn't have taught that well.